Give me a drape, please.
Got it.
Give
Can I
me a
get
drape,
some
please.
gloves, please?
Get her a glove and a
Which
gown.
size are you?
6.5, 7.
6.5,
Down. Either one.
Are you bagging the patient?
Yeah.
Do you have a pulse ox, please, or no? Nothing.
In the next few minutes, you'll see how using a realistic simulation such as the one you just saw, coupled with a well-developed audit tool, can dramatically improve team competency and patient outcomes. Reopening the sternum at the bedside in post-open heart patients is one of these high-stress procedures that requires a high level of team performance. To be effective, this procedure needs to be performed in under 10 minutes. In low-volume ICUs, where this procedure is performed only 1 or 2 times per year, realistic mock codes are imperative for training the staff. Assessing team competence in performing this procedure requires a realistic simulation mannequin and a tool to measure team performance. The mannequin needs to allow the team to perform the actual steps of the procedure, including removing sternal wires and use of a retractor to expose the heart to perform internal defibrillation or direct heart massage. The audit tool needs to provide quantitative and qualitative measures that can be used by the team to both assess and improve their performance. In particular, the tool needs to assess whether the proper decisions were made, the correct steps were followed, how long they took, and if everything needed for the procedure was in place. The goal of the procedure is to get the chest open as quickly as possible in order to access the heart. To assess team performance, an audit tool consisting of 5 parts was developed. The first is to measure how long it takes to open the chest. Timing. Studies show that opening the chest in under 10 minutes is critical to survival. The second is comparing team performance to the evidence-based guidelines, including how long it takes to decide if and when to open the chest during a code. The third is organizational support. Are the people and equipment needed available and in the room? The fourth is evaluation of team communication. And finally, 5 is lessons learned. This is data gathered at the debriefing used to analyze teaching techniques and the way we do the procedure. An important part of developing an effective audit tool is to have it assessed for validity and reliability prior to use. To assess validity, an expert panel composed of a doctor, a physician assistant, and 3 ICU nurses independently reviewed the form for both clarity and whether or not it was measuring what it was supposed to measure. After assessment, the expert panel of 5 had an 89 to 100% agreement on the items, thus demonstrating the validity of the tool. Equally important to validity is reliability. The question being asked here, will the tool deliver similar results when used by different observers? To test for inter-rater reliability, we had multiple observers use the audit tool during a mock code and then compared the results for consistency. For timing, we also compared the observers' results with the time as determined from video. Inter-rater reliability was found to be greater than 85%. The audit tool will only be useful if your simulation allows the team to perform all of the steps in the procedure outlined in the tool in real time. However, many low-volume, low-resource ICUs don't have the funds to purchase commercially available realistic simulation equipment. By being creative, we're able to develop a reusable, realistic simulation patient for under $50 by finding an old CPR mannequin and purchasing a few items from the Halloween store. In less than 4 hours, using a plastic heart and fake wound, we transformed an old CPR mannequin into a realistic simulation open heart patient that allowed for all the steps of the procedure to be performed in real time. The CPR mannequin was able to have its chest opened by cutting the suture of the chest incision, removing the sternal wires, and placing a retractor to reveal the heart, all in order to perform internal heart massage and defibrillation. Key to success of the simulation went beyond just the mannequin. The simulations were conducted in an empty ICU patient room with as much of the usual post-open heart equipment as possible. This included pacemaker box, ventilator, chest tubes, IVs, and internal defibrillator paddles. By combining a valid and reliable audit tool with a realistic simulation, we were able to document and improve team competency in this procedure. The first mock code performed by the team took just under 18 minutes. Based on team feedback, the video, and lessons learned, the teams now routinely complete the procedure in under 5 minutes in mock codes. Feedback from the nurses indicated that the realistic mannequin, combined with having most of the IV lines, tubes, respiratory and monitoring equipment found in a cardiac surgery ICU room, recreated the highly charged atmosphere of a real code. They felt that this was critical for their confidence in performing the procedure during a real code. We hope you took away 3 things from this video. First, even in a low resource environment, low cost, yet highly effective simulation and audit tools can be developed that will allow for teaching analysis, improve team competency, and staff satisfaction. Second, to be most effective, the simulation tools and the simulation environment need to be as realistic as possible in order to mimic real, high-stress, high-stakes procedures. And finally, it's through the use of an effective audit tool coupled with this realistic simulation environment that delivers measurable improvements in team competency and patient outcomes.
Exposed. Okay.
Huh? Watch the knife, sorry.
Go ahead. Open up suction tubing, please. Open up suction.
Retractor.
You have a rhythm bed.